Hi everyone, and welcome to another Live Safe Tool video. This video will focus on list costing, and this is the first video of the list costing video series. So overall, LiST uses the following information to calculate the total RMNCH cost. So first, LiST will calculate the cost associated with immediately delivering the intervention, so meaning how many drugs we need, who do we need, how much of their time do we need, those kind of very proximate calculations of how do we cost out specific interventions. And we sum that with the program costs. So the program costs are bigger picture supporting things that we need in order to be able to calculate, in order to deliver specific services, specific interventions. And so the sum of those two leads to the total RMNCH cost. And just as a brief overview of how LiST operates overall for this calculation, starting from the left, we use inputs about drug prices, salaries, to break that down into unit costs. So unit cost meaning how much does it cost to deliver one instance of the service, or cost per minute in the case of human resources requirements. And then we multiply how much do those things cost with how much do we need of them. So for drug prices, how many drugs do we need, and how much do they cost, and how many do we need in order to calculate the drugs and supply aspect of it. And similarly, for the salaries and the human resources requirements, how much of people's times do we need, and what type of healthcare worker do we need as well. And those will be costed out per minute. And finally, how much of their individual respective times do we need. We also add into that the cost per inpatient day or outpatient visit, depending on the service. Some services require hospitalizations, others don't. And all of that information together leads to the treatment inputs. And that in turn gives us the information of how much does each instance of that service cost. So now that we know how much things cost, we also need to know how much of it do we need. And in order to get that information, we will be using the target population, as well as the population in need, as well as the coverage intervention, either current coverage or target coverage, which is in order to calculate how many of those services we need. And those two pieces of information together lead to the total intervention cost overall. So starting with intervention costing. Intervention costing boils down to the quantity, once again, the quantity of services that we need times the price per instance of delivering that service, so the price per unit. In order to calculate the quantity, meaning like how many services do we need, LiST will need the target population, the population in need, intervention coverage, and finally the delivery channel, meaning how is this intervention actually being delivered to people, through what channel that is being done. In order to calculate the price, we need to know information about the drugs and supplies that are required per instance of the service, how much time do we need of each different cadre healthcare worker, and how much that costs as well. And finally, how many inpatient and outpatient visits are required for one case. And all of that together leads to our treatment inputs. So to dig a little bit more in detail, to find that number of services, it's actually just a simple multiplication between those first 3 points that we had on the previous slide. So we're multiplying the target population times the population in need times the coverage, and that will give us the number of services. So just so that you have a little bit more of a more concrete idea, using an example here for kangaroo mother care services, the target population will be the number of births. So in total, how many people are being born. The population in need will be the percentage of babies who are born premature. And finally, the coverage will be the KMC intervention coverage, the Kangaroo Mother Care intervention coverage. And all of that together will give us the number of kangaroo mother care services that are required at that coverage level. So to dig a little bit more in depth, the target population essentially is the population that could possibly receive that intervention, the total population that could possibly receive the intervention. And we get that information, or rather LiST costing gets that information from DEMPROJ. DEMPROJ has already the population divided by age as well as characteristics. So by characteristic, a good example would be pregnant women, who would be specific target populations. Or you have women of reproductive age, you have children under 5, neonates, et cetera, et cetera. So having the population, not all of the population will need every intervention, but this, not even need, I misspoke, not all of the population could possibly receive the intervention. So DEMPROJ will give us specifically that the target population that we have for that intervention. And the default data are preloaded into LiST, but as in everything in LiST almost, if the user has different data, better data, more accurate, more recent, et cetera, that he or she prefers to use for whatever reason, users always have that opportunity. The population in need, and this is why I corrected myself in the last slide, it's the population in need is the share of the target population, so the portion of the target population that actually does require the service, so the population that needs the service. And that basically boils down to the question or ratio between who should be getting their service and among which group. So if we come back to our KMC example from previously, who should be getting the service? That should be all of the babies who are born premature. Among which group? Well, that would be amongst the total number of births, so all babies. Coverage, we've seen in other videos, but just as a brief reminder, coverage will be who among those who need the intervention actually is receiving it. And that data will be taken directly from LiST coverage editor. Finally, the delivery channels will have an impact on how the intervention or the service is being delivered. So pre-calculated in LiST costing already, we have some costed channels. And the costed channels are all the channels that are delivered through health-related government entity. And by that, we mean essentially the Ministry of Health. Typically, it will be only the Ministry of Health, but in some cases, you might have some Ministry of Health adjacent institutions that could be delivering services as well. But it needs to be government, and it needs to be health-related. So that would be essentially community, outreach, government clinics, government hospitals, that kind of thing. So LiST costing will already have those channels costed in the software. Non-costed channels, so channels that LiST does not have by default costs associated to it, are the interventions that are delivered through any other channel. So that can mean either private clinics. Private clinics will have a very wide variation in how much people are charging for things. So because of that, we don't have a steady, reliable data source for private clinics, so that would be user-entered data. Or things like WASH interventions. So there are some interventions that are not delivered through the Ministry of Health, but that do have an implication for health. So sometimes some interventions are under the purview of the Ministry of Education, for example, maybe Public Works for making sure that people have access to clean water, things like that. So it's outside of the Ministry of Health. It can still be government, though. And as mentioned, these are channels that are not costed in LiST by default. And once again, it's up to the user to enter that information. To give an example, for the delivery channels, the total always needs to sum up to 100%, and this will give the percentage of the total instances of that intervention that are delivered through these channels. Well, through those respective channels. So just to sum it up, in order to calculate quantity, which is what we learned to do just now, we need the target population, so who could possibly receive the intervention. We need the population in need, so what share of the population actually requires the service. We need the coverage, so who among those who need it are actually getting it. And finally, how is the service being provided? So through what specific channel?